started in the interest of time. I want to be mindful of your after plans for the afternoon. So I'll go ahead and get the webinar started. I still see people trickling in, but hopefully they'll be able to catch up. So good afternoon, everybody, and welcome. On behalf of the Women's Caucus and the LGBTQ Caucus of the American Public Health Association, I want to thank you for joining us for part three of a critical discussion: federal funding cuts, the threat to sexual and gender minorities, and women's health research programs and services. My name is Cynthia Armand, and I'll be serving as your moderator for this hour. We're here today because the stakes have never been higher for women, for LGBTQ plus communities, and for every marginalized group fighting for basic rights to live healthy, self-determined lives all across this country. In the states and after states, we're witnessing an unprecedented and coordinated attack on women's health protections, on reproductive freedom, and on gender affirming care, and on the very foundation of public health. Since the fall of v. Wade, harmful legislation has swept across the nation, banning on several restrictive abortion, defunding reproductive health programs, and targeting LGBTQ plus care, and undermining public health infrastructure. These laws are not just political statements, they are policy choices that put lives at risk. They harm all women, rural communities, and those already pushed to the margins. We're seeing the effects in real time. Clinics are closing, maternal mortality is rising, and essential services are being defunded. Entire communities are being left without access to care and preventative services. So today, we will hear from leaders who are on the front lines of this fight: organizers, researchers, practitioners, and advocates. We are honored to be joined by three incredible panelists that will share insights into what's at stake, what's working, and what we need to do next to protect the progress we've made and push further and beyond. Before we begin, a few quick notes. This session is being recorded and will be shared with all registrants. You're invited to share your thoughts or questions in the chat box throughout this discussion, and we will reserve time at the end for group reflections and a brief Q&A. So feel free to react throughout the whole session and use the tools to engage with our speakers. So with further ado, let's begin our panel conversation. I will again briefly introduce the panelists, and then we will dive into questions. So we have Dr. Amy Heckenberg, Associate Professor at the State University of New York at Buffalo. We have Allison Bauer, JD, MSW, who's a teaching professor and associate chair at Northeastern University. We have Dr. Megan Smith, who's an associate professor at Boise State University. So good afternoon to you all. Thank you for being here. I will go ahead and start with Dr. Amy Heckenberg. I will have two questions for you. If you need me to repeat the questions, let me know. I will start with the first. So as someone who provided a declaration to a lawsuit to HHS and NIH because of funding suspensions, can you discuss the impacts the funding cuts have had on your research and at academic institutions? How can researchers and public health professionals continue to advocate for continued research funding?
First, thank you to the APHA Women's and LGBTQ plus caucuses for inviting me here today for this really timely conversation. And to answer your question, let me give you a little bit of background about our grant termination and reinstatement for context. On July 21st, my co-PI, Jennifer Livingston, and I were abruptly notified that funding for our NIH R01 study was terminated shortly before the end of its fourth year. The grant was funded as a 5-year mixed methods longitudinal investigation to examine protective and risk factors linking peer victimization with alcohol use and other adverse health outcomes among LGBTQ plus adolescents. The grant was scored at the first percentile when it was funded, indicating that the reviewers felt very strongly that it was significant, novel proposal, rigorous approach, strong investigative team, etc. However, according to the termination letter, and I'm paraphrasing here for time, but the award no longer effectuates agency priorities because research on gender identity is unscientific, has little identifiable return on investment, and fails to enhance the health of many Americans. It also ignores biological realities. The notice also indicated that we had no recourse for appeal. The termination was effective immediately, leaving our staff unemployed with no notice, and we were left no funds to, conduct closeout activities. Fortunately, our university gave us some bridge funds. We were able to keep our staff for a little bit of time to do, the closeout activities and collect a tiny bit more data. Shortly after that, our general counsel at the University of Buffalo contacted us and requested that we provide a declaration detailing the impact of the termination in order to accompany a multi-state lawsuit against NIH and HHS for these terminations. We in that declaration we underscored the loss of knowledge to improve the health of LGBT plus adolescents. We emphasize that termination in the fourth year of our longitudinal study prevents us from achieving the funded aims, which translates to significant and financial impact. Loss of money invested by NIH and the American taxpayers. We also emphasize the stress and financial impact on our staff who lost their jobs, and our graduate students' loss of opportunities to gain research experience as part of our study team. So on June 16th, the court, you probably heard, the case was heard by Judge William Young, a U.S. District Judge for the District of Massachusetts. And he concluded that the termination directives were arbitrary and capricious, and he said they should be vacated and set aside. In follow-up commentary, he said that the terminations were discriminatory, and he felt it was his duty to call that out to the American people. As expected, NIH and HHS immediately appealed the outcome. So our grant was reinstated on July 8th, and we still don't have our funds available to hire our staff and restart data collection because we're really caught in a vortex of bureaucratic uncertainty, and we're not the only ones. The title of a recent article in the Chronicle of Higher Education really sums up our situation. Their NIH grants are back, but nothing's back to normal. The delay in receiving our notice of award is certainly related to the loss of NIH employees necessary to reinstate the grant, but the most salient reason right now is that this situation is really unprecedented, with no existing guidelines or policies to guide administrators at our university who are trying to reinstate the funds. I could spend an hour telling you about the lost time and energy, added stress we've experienced while submitting reports, justifications, participating in endless meetings about the reinstatement. We do remain optimistic despite this, but we have a lot of anxiety that something's going to prevent the release of our funds and will be terminated again down the road. And I have to say, on a personal level, our grant termination and the ensuing climate in our nation has been soul crushing. And I really don't exaggerate to say that my entire professional career has been devoted to understanding and addressing the factors that result in health disparities among SGM populations. Following this termination, I've been asked more times than I can count how I plan to pivot to continue to conduct my research. I feel deeply conflicted about this question, which is inevitably followed by very well-meaning advice about how to covertly continue my research by scrubbing it of anti-executive order phrasing or securing funding by camouflaging my actual target population among larger samples of populations deemed acceptable per the executive orders. And when I say this, I want to be clear that I'm not judging anyone who uses these strategies. I'm really fortunate to have job security through tenure, but there are many, many early investigators who conduct similar research, and they're forced to take this route to achieve the research milestones they need to get promoted. And all those factors are hazy and unchanging and becoming increasingly unrealistic. And I also acknowledge in the current climate, we can't advance LGBTQ plus health research without sufficient funding. Private foundations those funds are available, but they're really limited and they don't typically provide salary coverage, which is necessary to have protected time for investigators to have protected time to do their research. And I know desperate times call for desperate measures because otherwise progress is going to halt. We have the last 2 decades of advancements in this field and they're going to be severely compromised. So I acknowledge that we shouldn't give up. I also must admit that the thought of conceding to these pressures by scrubbing or pivoting makes me feel dirty and traitorous. Such actions really threaten, I think, to quietly erase LGBTQ plus people's identities and subjectivities, and it undermines people's rights to live their authentic lives. Essentially, I worry that embracing these strategies reinforces the values conveyed in our termination letter, that what we do is unscientific, yields no return on taxpayer investment, and fails to enhance public health. So what do we do? Well, first of all, I have come to acknowledge in this climate that as an academic researcher, I've been really myopic in my dissemination of research results. I often stay in my safe ivory tower. I feel that, I've really not done the work that's necessary to help lawmakers, general public understand the importance of research and real life implications for people who are, our neighbors, our coworkers, our loved ones. So I think we need to move outside our safe spaces, and I'm still figuring out how to do that. I also believe that we need to use our science to clearly emphasize LGBTQ plus health as the public health priority that we all know it is. We need to use our knowledge gained from experience to highlight disparities. We need to clearly demonstrate the cost of not providing care and preventative services. Um, we need to show that our research is fiscally responsible. These are new skills that we need to cultivate ourselves, me along with everyone else. What are some other things we can do? We can write op-eds, we can do policy briefs, we can provide accessible summaries about our research to inform the public. I recently took a really awesome workshop by the op-ed project, and they gave me really new skills to do this because we're not taught how to do this in academia. We also need to demonstrate real world impact. And admit that that's sometimes challenging when we're conducting foundational research because it's meant to inform downstream intervention efforts and so on. Um, but we need to really effectively explain in accessible language how our research matters and its importance for improving people's lives, even if it doesn't result in immediate impact. I encourage people to collaborate with LGBTQ plus advocacy organizations like the Human Rights Campaign, Lambda Legal, donate to them if possible. Get involved with nonprofit agencies in our communities. I'm on a board for the local LGBTQ plus youth services agency, and it's been immensely rewarding and also gives me optimism. We're in New York State, and so we have some freedom and have been able to provide a lot of supports. And we can actively participate in advocacy efforts through our professional organizations like APHA and the Gay and Lesbian Medical Association and the APA. So that was a lot.
Thank you for your insightful answer. Just one more question for you. From your research on minority stress and interpersonal violence within LGBTQ plus populations, what role should federal policy and funding play in supporting programs that address these issues? And what specific investments or legislative actions would you recommend to enhance health equity for these communities?
Well, as you can guess, and probably why all of you are here today, I really believe that the future of science in our nation is in jeopardy with these grant terminations. And the cut really is going even deeper as future funding opportunities, our priorities, our awards are driven by politics rather than public health. And, even the rigorous peer review process that's been the hallmark of science in our nation is being quietly dismantled as we speak here today. LGBTQ plus health research only began to like really earn recognition as an important public health issue in the last 2 decades, and it really scares me to consider how that progress is being quickly undermined and erased. Having been a scholar in the area since the 1990s, I'm dating myself. I can attest to the significant expansion of what was initially a relatively niche and very underfunded field to one that's now internationally recognized as a critical public health science resource. Tragically, many of the key developments over the past decade that have supported this growth have been erased during the first few months of President Trump's time in office. For example, we all know that data collection efforts that are needed to understand the health status of SGM folks and women at the national, state, and community levels. They've been dismantled. Some of them, disappeared off the internet for a while, came back with, um, you know, caveats attached to them. These data, as we know, are really critical to understand the state of SGM populations. And they inform, local service agencies and provide them with important data to serve their communities. And, we all know too that in 2011, HHS they formally designated SGM populations as a health disparity group for NIH research purposes. And that was really a critical juncture in the timeline for acknowledging the persistent inequities in physical and mental health outcomes among this population. And that designation has been removed. we saw that the NIH Sexual and Gender Minority Research Office appeared in 2015, which was amazing. This office really catalyzed a surge in funding opportunities, expanded SOGI data collection, broadened the scope of health research beyond the HIV/AIDS area to include mental health, chronic disease, healthcare access, aging, etc. One of my most vivid memories from the early executive orders was when we discovered that this research office had disappeared off the internet. I get like goosebumps thinking about it, and it hasn't been reinstated. So, sort of a more direct answer to your question, I'll be super honest that I don't have a crystal ball to figure out a way out of this mess. This is all a work in progress. And in the meantime, the clock's ticking as these losses are crushing blows to SGM health research. We need to keep speaking to our legislators to help them understand how and why LGBTQ plus research is so important. And as I noted earlier, we need to explain the real world impact of our work and the significant public health implications. The number of people identifying as LGBTQ plus in our nation are increasing each year. And no one's going to disappear just because dominant narratives demand it be so. So we must continue to figure out how to keep what we still have and restore what we've lost. And we can't remain silent, which is why I'm really thankful to be here today to share our experiences and strategies.
Thank you, Dr. Heckenberg. We will move on to Professor Bauer. Your first question is, your work focuses on health equity and the social determinants of health. You have also worked on reducing excessive healthcare spending through preventative measures. We also know that public health is at its most effective when it's invisible. What messages can we take to policymakers on the effectiveness of preventative public health work and continue focus on the social determinants of health?
Well, thank you, Cynthia. And I want to also just thank the Women's Caucus for joining with the LGBTQ Health Caucus, of which I'm on the executive committee. So I love the partnership. And I think later on, I'll talk a little bit about the importance of partnerships to move forward. I also think that the question about is public health at its most effective when it's invisible? Maybe it's not that it's at its most effective, it's just that it is often invisible when it is very effective, but it is often invisible. And I think that in addressing preventative public health and social determinants of health, two spaces that I've worked in with my background in government and philanthropy and now in teaching, the idea that invisible success is still real success. I always joke with my students that, when you were young and you came home with that great exam and your parents stuck it up on the refrigerator, right? When public health is really successful, we have nothing to show for it, right? Look at how many things we prevented. There's nothing there. But results aren't really invisible. They need appropriate attribution. That's kind of the way I think about it. If we're able to emphasize that preventative efforts yields long-term health, that it yields economic benefits, that every dollar spent on prevention, and that prevention includes things like vaccination, cancer screenings, harm reduction, which is its own, issue to deal with, healthy behaviors, all of that reduces costs. There was a study put out in Health Affairs in 2020 that showed for a 25-year period from 1990 to 2015, 44% of improved life expectancy in the US was attributable to public health interventions, the things I've talked about, as well as tobacco reduction or wearing seat belts, infection control, infant sleep safety, all of those pieces. Medical advantages contributed to a 13% increase in life expectancy, and pharmaceuticals, which get a lot of attention and press, and particularly in the US, a lot of time on our television screens with advertisements, contributed 35% to overall gains. And so even though there were gains across all of those areas, public health and preventative public health actually contributed the greatest amount. So I think our ability to articulate that and to lift that up. Amy, you mentioned that getting out of your space to be able to present to other places that often don't feel comfortable. I think presenting the evidence is a big piece of that. Using public health messaging to make clear that upstream investment in prevention and social health interventions saves money, improves outcomes, reduces the burden on hospitals. And I think the best part about that particular message, as somebody who's worked in federal and state government in both the executive and the legislative branch, is that that message, the economic message, as much as we like to take the moral high ground and say we should be doing public health for public health reasons because it's the right thing to do, we need to be able to expand our message to an economic one. And I think the economic message, the reduction of burdens, the cost control message, has the potential to reach across political divides at a time when that gulf is as wide as I've ever seen it. As somebody who started in the political world back, also dating myself, after law school in the early 90s in DC, working in politics, working in the government, working on campaigns, this political divide is as deep as I've ever seen it. But a message of fiscal responsibility resonates across the political spectrum. And I have no problem. I don't want to cede the message of fiscal responsibility to one side of the political aisle. I think that we, as public health advocates and as people who focus on this, need to be able to take that message and make it our own as well. For example, United for Medical Research, an organization that puts out reports. Their annual economic report says every dollar in NIH research funding generates 2.21, so over $2 in economic output in terms of jobs for individuals, in terms of the savings. Like when someone's not sick, they're contributing to the economy. So we're able, I think, to be able to have a two-part message. One, public health improves life expectancy. We contribute more to the economy. We have far fewer negative health outcomes, right? But also, we have this great economic outcome. We know that, for example, the mental health disparities faced by gender and sexual minorities cost the US economy 25 billion. Why does it cost it in lost productivity in healthcare? It's not just that we've got more healthcare costs when we're not keeping people healthy. People don't come to work. People need to be replaced and need to be and people have to be hired to take their toll. So I think if we could get our heads around owning and really lifting up the economic message along with the public health messages, that would make a difference. And I know I mentioned gender and sexual minorities, but women, misdiagnosed or untreated or undiagnosed conditions in women, in part because of gaps in research, and we know those gaps are only going to get worse, contribute 20 billion annually to excessive healthcare spending. And again, that comes from McKinsey. So I think that while it may be a less comfortable space to be able to lift up some of this messaging, using some of these economic messages has the opportunity to perhaps make the case that we're not taking a political stand when we say we need to do this research and that we need these dollars at the federal level. It's that we're taking a stand around lifting the whole of the economy and not having one, unhealthy humans, but also lost productivity and losses to the economy that come out of other places, right? We see those losses have implications across the economy.
Absolutely. Second question for you. As someone bridging law, policy, and community work, how can we ensure that sexual and gender minorities and women are centered in public health funding decisions and healthy policy development?
Yeah, I mean, this is obviously a hard question in a current political climate where certainly my health policy class, students sat there as I lifted up on the screen the 300 different words that you couldn't use in research. And again, I'm here in the presence of a couple of researchers who can speak to this. But I think the answer here is often, data, 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 and data. That's my answer. This is the biggest issue because without data, it becomes much more challenging to demonstrate the need for funding and policy development for these communities. And in fact, it's exactly why I think the efforts being made to take away the ability to provide that data, to articulate that these are populations we don't want to collect data on. And if you will indulge me, I'm going to use an example actually from the 1990s that has nothing to do with women or gender and sexual minorities. But the Dickey Amendment was an amendment passed about gun control back in the 1990s. And it prohibited the CDC from using federal funds to advocate or promote gun control. Well, what happened was, as a result of that, it was interpreted as a ban on any CDC funding for research that could lead to any gun control measures. And so, as a result, there was such a steep decline in any funding. How could you advocate for gun control measures based on data that said that we had a gun violence problem because there was no data to show we had a gun violence problem because the CDC wasn't funding any research on gun control. And that chilling effect on researchers really deterred them from pursuing studies that in any way could then support gun control. So a lack of research leads to a gap in knowledge, which makes it harder to then develop effective prevention strategies. And so it's kind of with that in mind that I sort of want to, kind of refer back a little bit to what Amy, you were saying about, or do you change your language, right? Do you change the language? Do you stand on ceremony? There's a phenomenal researcher I've worked with around preventative health here in Boston. Her name's Dr. Elsie Tavares, and she spoke at our campus at Northeastern just this past semester. And it was clear that her general counsel had to review her presentation. She also said we couldn't record her presentation and show it because her slides couldn't be made public. She had to control her language. And I worked with Elsie during my time at the Boston Foundation and then again at the state and now at Northeastern. And what she said, which I think really resonated with me, and she's a Latina doctor who works on particularly underserved minority populations and health outcomes from an early age. And what she said was, I would rather change the language and continue the work than stand on ceremony of language and not be able to continue to find ways to advance what we need to do. And so if you ask me from the perspective as a legal professional, as a policy professional, as somebody who's worked around both creating and writing the laws and helping draft laws at the state and federal level and then advocating for them, I think we have to be willing to be creative in how we're articulating what we're doing and how we continue to figure out how to have, equity metrics or figure out how to lift up the issues of intersectionality, which of course show up really nicely in this with the women and gender and sexual minority groups coming together. Use whatever community voices we can to amplify the issues to recognize what's happening. And, honestly, demand some accountability, transparency as much as we can in the funding streams, what's happening. But we're going to have to be clever and we're going to have to not stand on ceremony while we navigate this moment in time, trying to hold as much as we can what we need from a data perspective to be able to articulate and to keep the centering around the populations we're serving, even if we have to use other words to be able to put that data out there.
Thank you so much, Professor. Last but not least, moving on to Dr. Smith. Your first question is, adolescents have been experiencing mental health crisis prior to funding cuts. How are you and your team collaborating with community engaged partnership to uplift adolescent mental health?
Yeah, so I appreciate this question, and I'm in the presence of queens. So thank you, everyone, for being here today. I'm very grateful to be part of this conversation. Um, you're absolutely correct. Adolescents have been in a mental health crisis. We also know, as Dr. Hecklenberg mentioned earlier, that adolescents who also identify as SGM populations have higher rates of poor outcomes that we're trying to avoid. And I do this work in Idaho, which y'all can make your own assessments about what that work looks like here. We leverage, I would say, kind of echoing what Professor Bauer just mentioned, we leverage doing the work that needs to get done in every way that we can. So we play the short game and the long game all the time, and we do what we can when we can. And I'll be more specific about what I mean by that. One is we lead with relationship and trust building. So we go as slow as it is necessary in every single community, one community by one community, right? Because as we all know, our populations are very divided. And so the way that we overcome a division in one community can look very different than the other. Similar to what Professor Bauer said, the way that we can speak about the adolescent mental health crisis, even in Idaho, changes by community to community. And the approach we take sort of changes, but the work, the outcomes continue to be the same. And I actually think as public health professionals, man, we are well trained to meet this problem. And I think right now it's hard because we're having to shift the way that we typically think about problems and the way that we typically approach problems. But we are trained to understand community engagement, and we are trained to understand prevention. And prevention, particularly when we think about the focus on protective factors, right? When we want to lift up protective factors, regardless of your ideology, your politics, etc., when we say a protective factor in this community, when we look at our data analysis and we see that connection is what these young people need, we can bring a community around connection without hitting any of the hot buttons, but we are still doing the work. So I know it's challenging because some of us have been trained in the 90s social justice warrior, and believe me, I'm with you. I was trained UC Santa Cruz, we're going to go and burn everything down. And there is always a place and a need for those humans. But I believe in public health, particularly around prevention work, we are uniquely trained to sit with communities, to build the trust and relationships that allow us to take more steps forward so that whatever the ideology or the politics around us, we are still connected and trusted in that community. And so we go really slow. We also don't throw the baby out with the bathwater. So if a community is like, wow, we are really not ready to ask that question right now, we can say, okay, let's build some time with you. We'll spend a couple of years in your community. We'll do focus groups instead of surveys. We'll do what we can until you see us as a trusted partner and we're not coming in with some political agenda or a liberal, researcher, outsider perspective. So we do a lot of work around building that relationship. And again, doing what we can when we can. So if we have to focus a community around, hey, all the young people in this community need this, and there are certain populations who need it more, we have those tough conversations. I would say one of our most successful things in building that trust in communities is through having listening sessions in those communities and really going in without our approach right off the bat, rather listening to the community, because the community will tell us, ooh, please don't use the word mental health. And we're like, oh gosh, we are on a grant for mental health. What do we do, right? And we've been able to talk about what that looks like. So in some of our communities, we're talking about the well-being of young people. And we know that mental well-being and social well-being are a huge part of well-being. And in fact, our communities can listen to it if we just start with, we're working on well-being. We're trying to make this the best possible place for kids. And so we've had success there. We've also had success in doing the listening sessions in small enough groups that I say keep people in their humanity. So early on when we started working with schools and communities and we were like, we're going to work on mental health, our school professionals were like, please don't make us say these words to the public, because they were literally in experiences where parents were like yelling at them at the mic at board meetings, right? Like that was their experience. And they're like, we've just been head in hands when people yell at us. We don't know how to handle this like public interaction. And so we've kept people in their humanity by having a trained group facilitator from my team, again, public health professionals, sitting with about 8 individuals in that community and engaging in the tough conversations, engaging in conversations about transgender youth, engaging in sexual minority. And, you know, when people are in a group of 8, it is much harder to just launch off. I'm not saying we haven't heard hard things and that we don't train our team. We absolutely do. But it is in that moment when we are sort of forced to stay human and forced to have that conversation in a way that feels safer and less like we have to grandstand and show our identity to the world, right? And we've made some small progress there in ways where I'll give you one specific example. A person who was very convinced that transgender youth were experiencing what they would identify as like a mental health crisis, and that we just needed to get them kind of out of our population and then all mental health would be fine. In that same conversation, after engaging with other people of their community and different perspectives, they said, I'm quoting this, I wish it were fake, but it's real. He said, I guess we need to have safe spaces for those kids too. And I think that is the power of using our ultimate skill, which is mind on the prize, right? Prevention, good outcomes for young kids. What do we do? And I think public health professionals are uniquely positioned to be the transformers in our communities, in our world. And it is by being patient, by doing what we know is best, which is like deep, rich, authentic community engagement. We have to get rid of that community engagement that's like, we sent them a pamphlet and they know stuff now. That is not real community engagement. And so when we go deep and take the time it takes, then we can make real progress and change. And the best part, y'all, is when we go slow, it sticks. So it's not just a 2-week program that comes in and out and we're like, okay, we made some cool 2-week outcomes. It is in the ethos of that community. And so, okay, I'm saying too much, so I'll stop and let you ask your other question. Oh, Cynthia, I think you're on mute.
No, you're getting some thank you. You're getting some claps and hearts from the
Thank you.
audience. So I appreciate your insight. One more question for you. You've navigated working in an environment that may not be supportive of collecting data points. You like such as asking if students are LGBTQ.
Mhm.
How are you maintaining fidelity to your data in this time of executive orders seeking to limit research on terms such as equity, gender minorities, and etc.?
Yeah, I think there are all sorts of creative approaches to this, and we've touched on some of them before. I think one approach is thinking about how we collect data, and I know it is much easier to have a bunch of categories that young people check. However, we know those categories are disastrous in some communities, right? For instance, if we even say other as a gender option in some of the communities I work in, it is a disastrous mess. However, I will tell you that although we get a little pushback, we've had great traction even with some of our very conservative members of our legislature and some of our other, I don't want to name them just for their safety, but we've had really good, we've been able to keep the gender question on our survey by a fill in the blank box. And I will say, of course, when you're collecting data from over 15,000 teenagers, it is a huge bummer on the back end to code that data. However, it is so worth it. And I will tell you, our team has actually learned more as a result of doing it, because there have been gender identities I did not know young people were using. And so it has actually been really beautiful and valuable. And it allows us to just get past that first, again, kind of echoing what Professor Bauer said, it allows us to get past that first, like, push, right? Like if they're going to be hostile to a survey anyway, we're not going to say, okay, now there's two-spirit as an option and you have to accept that, right? Instead, we're going to say it's just a fill in the blank box. Now that got pushback because it brought attention to it, right? So then, oh, y'all, in this huge survey data collection we do, we also made all our demographic questions fill in the blank, which, yes, is a nightmare on the back end, but it allows us to say, this is how we collect demographic information. It is so that we're not putting any values on your young person, because that is one of the concerns, right? That we say other gender and their kid is like, oh, now I have another gender because I've seen it on a survey, right? And so we're just trying to keep that open. I will say we've had harder, at least in our context, around sexual identity. So we had it on our survey the first couple of years and then it was removed. And so we have kind of been able to use some of the first data collection and also the national data collection to identify where our data shows a trend that we know would be heightened in that population. So for instance, in communities that don't allow us to ask about sexual gender, or sexual identity, we are able to say, hey, this is what we're seeing as a trend with those who identify this way, those who identify this way. And we know, based on data writ large, that this population is going to have probably higher outcomes and that they are among us. We also follow up with focus groups. And so sometimes our young people will just naturally engage in those conversations. And that is great information that, again, we can be the adults in the room to communicate it through to the other adults we hope join us in prevention around those populations. I am not saying it's easy by any means, but I think these are the ways that we continue to raise up those populations and support them, even if we have some roadblocks in the way. And then the final thing that I meant to mention in the last question that I think is really important for us, again, as public health professionals, and I think this echoes what both Dr. Heckwenberg said and Professor Bauer. I'm just going to raise up Caitlin Jetlina. She goes by the name Your Local Epidemiologist. She's become a leader in communication for public health issues. And she and other extremely talented researchers and thinkers around this topic and in public health's future have said we need to shift or change our communication style. And they're calling for what they call more informal social media type conversations. And I know for some of, especially me, y'all, like I do not like being on the screen. As you can tell, I'm nervous talking really fast. But she advocates for the fact that that by and large, young people and older generations are getting their news and getting their information from informal sources on the social media or other such platforms. So that means to us that our old, like, here's a flyer from the public health department approach is not going to cut it. And so I think those of us who are ready to get uncomfortable, like Dr. Heckenberg mentioned, that is a space that we can be uncomfortable in, that my team is definitely thinking about. How do we get into that social media space? How do we create those parasocial relationships with our communities so that when we say things that are factual and based on evidence, rather than a lot of the voices they're hearing right now, that we are their trusted source? And I would say that is one future pivot of public health, of where we can continue to, again, build that relationship. I know it sounds weird on a social media kind of platform, but build that relationship with our audience so that we are the trusted voice. And so that when we mention sexual gender minority populations and their needs, it is already valued. We've already created that connection. And so that would be my last kind of tidbit of information there.
Thank you, Dr. Smith. So now I have two questions for the entire panel. The first question is, what strategies are you using to continue to advocate for sexual and gender minorities and women's health in your work? And what have you seen made the largest impact thus far? So anyone can volunteer to go first.
I would defer to my colleagues on that because I think their research can speak to that a little bit more, and also note that I think that your question lifts up another question that's in the chat about if you have to scrub gender from your research and it can't be funded, how do you collect gender data? And I'd love to defer to them, and maybe I'll think about the second of the open questions.
I think you're ready to answer that, Megan.
I mean, I think I sort of talked about it a little bit already, but I would say the more my suggestion would be the more local you can get. Obviously, there's federal advocacy that we need to be a part of, and I forget which one of you mentioned it, but that can be done through professional organizations, lifting up APHA calls, lifting up, for instance, I'm also a member of the Sophie Advocacy Committee. So these are groups that are working at that federal level. So you just lending your time, talents, and treasures to those opportunities at the federal level is great. But in your own day-to-day life, the more local we can get, the better. And so, for one example, in West Virginia, when I was living there, we worked city council by city council to get a non-discrimination ordinances passed because we could not make any moves at the state level. And so when you get local, you are literally talking to people who live in your community. And it is, I'm not saying it's perfect. I'm not saying they're like, okay, Meg, let's do it. But the more local you can get, the more people around, again, I think it's because you're keeping people in their humanity. When we work with school communities, even rural communities who don't want to hear about mental health or these SGM populations, it is really hard for them to look away from the 400 kids that are in their care every day, right? The 400 kids that live in their community. And so we present data at a very, very local level to them. And we open up conversations about that. So we're not saying like, you must do this, you must say this, but instead it's like, hey, this seems to be something that we're grappling with in our very own children. What can we and what are we willing to do about it? And so I think I know it feels slower when the nation feels like it's a big mess, but you have more ability to make quicker change the more local you get.
Yeah, and I would tag team on that and circle back to my point about developing relationships with nonprofits and community-based organizations. We have a very wise executive director in the LGBTQ plus youth agency that I work, and he emphasizes, no one can do everything. You can't. We have to we have to work with our skill level, and we have to develop relationships and networks so that, maybe I'm not the person that's going to be good at advocacy, but I'm the person that's good at providing mental health resources, et cetera. And so by coming together as a community, and he's been working very, very hard in Buffalo to establish those networks and bring folks together and pool resources, given the possibility that, we may be losing grants, et cetera, that support the work that we do.
I would tag team to that, and then I don't know, Cynthia, if you're gonna pivot to that last question, because I think
Sure, if it
but
flows in well.
yeah, I think it flows a little bit, but the question someone asked in the chat about how do you move forward if your funded grants can't collect gender data? One, I'd say my colleagues have answered that well, but the other thing to remember is that 51% of the US population are women. So if you generally collect data, you could articulate that we know here's data and more than half of our population is represented in this data. So even if people aren't identifying themselves as female, we know writ large that's our population. Again, I think the numbers for sexual and gender minorities, it's always been this crazy, like, is it 10%? Is it what percent? We know that's underreported. But again, we can use writ large percentages to eh, um, to say this data applies to this pop. It's not like we're taking everyone out of the research. We're just not calling it out specifically. So I would note that. And then just to flow, I think if you asked about you asked us to prepare what glimmers of hope. And I would say just what to lift up what both Megan and Amy have noted. One, really positive signs for US public health are around state and local initiatives. Some places it's statewide, like where I am in Massachusetts. I think where Amy is in New York, we get to maybe do a little bit more statewide, but Megan's lifted up how well you can do work at the local level, even in a place like Idaho, which I think statewide has not been the most supportive. I think we use, again, the lawyer in me, we use the courts using court orders. Amy, your grant was reinstated because, again, on its way, hopefully, but because of a court order, right? And so we have to use the courts. You also mentioned non-governmental organizations, nonprofits. We need to partner with community, because then we're not coming in to say, this is what you need or this is what has to happen. People from within the community are lifting up and saying, this is what we need. And we are asking them to help us. A colleague of mine from the foundation used to use this expression all the time. And my students, any of my students or former students who are listening will know this, don't do anything about me without me. And so if we can hold true to that, that's really true community-based public health. And then I think the other piece, which is cuts are terrible, but when we lose resources, we get creative. And I think that often we can get stuck in our silos. And if a glimmer of hope that comes out of this are innovative collaborations, like just this webinar is a collaboration between two groups. This is a microcosm of the type of collaborations we need to figure out how to lean into. And I also answered this in the chat to somebody, but how do I keep myself excited? I think of every student who sits in front of me as a teaching professor as a potential point of hope moving forward. And so that's actually a huge piece too. That is, I think, a sign of life is that we still have people coming and studying public health, and that means everything. So
Absolutely. We flowed into the second question, so I'll open it up to the other panelists. Again, the question was, what glimmers of hope do you have for us? How are you taking care of your mental health?
I'll just add one more thing, and this will make anyone who's listening who knows me laugh, is that I just play a whole lot of tennis. I play a lot of tennis that takes care of my mental health. I'm out there on the tennis court, and I'm telling you, when you're trying to hit a tennis ball, you can't be thinking about what's happening anywhere else. So that's been a huge piece for me.
I love that. Any other responses from the panel?
Um, I think the glimmers of hope that I see most clearly right now is working in the community and seeing how folks are prioritizing their services, collaborating with others to cover gaps in services, and really coming together in ways that perhaps they weren't before. And and Buffalo is not a big place, and there still can be silos among nonprofits and community providers. And I think that this is forcing people to dismantle those barriers among communities. And I have hope for that. And in terms of like taking care of myself, I dig in the dirt. I'm a big gardener. So, and I also have been, really keen on bringing other researchers together to talk about, we just put together a roundtable presentation abstract to go to a conference and have folks come together and have discussions like this. I think it's so important to keep this up because it's not a stagnant conversation. We can build on it. I learned so much today from all of you, and we all are better when we have these conversations.
Yeah, and I tend to lean on hope a lot, which means then when you let in all the darkness, it can feel very disorienting, right? So there is a lot of hope, as part of the work that we do in these community engagement efforts around adolescent mental health. We use or we work with what we call our teen action teams, and they're teams of 13 to 18-year-olds that work on lifting up the message of prevention. So before they've even identified as public health professionals, they're thinking about what are the real protective factors in their worlds. And I think that can create hope. Similar, I'm going to echo Professor Bauer, my undergraduates, my graduate students, the people who work on our team, I know they are going out with the same flame or fuel that I am, and that is powerful to know that there are groups of people who are not going to give up no matter what, and they're going to do what they can when they can, and recognize that if we just focus on what we can't do, then we don't move forward. So, okay, you're telling me this block, this block, this block, how do I get through right here, right? And that is always the mentality. So that is hopeful for me that there are people that will continue to just not focus on what we can't do, not focus on the barriers, but focus on what we can in fact do, and that there is always something we can do. And then as far as taking care of our mental health, I generally kind of hate these questions because all of us are probably not that well, if we're honest. But I think, you know, it helps me to remember that we are a chorus, and it's cliche, but sometimes when I get overwhelmed with all the things going wrong, it seems, in the world, I just feel completely at a loss and out of control. And then I remember we are a chorus. So I am doing my part of the singing and the work, and other people are doing their part. And so when I meet, for instance, an environmental health policy researcher, I'm like, thank you, because I'm not doing anything over there, but I appreciate that you've got that ball. Don't worry, I'm working over here with youth mental health and suicide and prevention. And so I think reminding myself of that instead of feeling like I am not doing anything to actually make change, and instead saying, yes, I am part of a chorus, can kind of help me when I start spiraling, as I know public health professionals can do.
Megan, I think that point is such a great one. And I also want to not make sure we don't forget APHA as an organization that's helping us. There's a book by Timothy Snyder called On Tyranny that he wrote during the first Trump administration. And one of the chapters, and it's a very small pamphlet, I recommend everyone read it. But he says, you know, defend institutions. And like, you can't, like, they're throwing so much at us. We each have to stay in our lane and do what we can do, knowing the person next to us is doing what they can do. And that does make us feel a lot stronger. And I will note, like the LGBTQ caucus, we requested, put in a notice to try to get APHA to accept from us articulation of a policy statement on gender affirming care, and they've accepted that we will be bringing that forward to them. And it's a long process to get there, but if APHA comes out and makes that statement, that's a huge statement. And so we're continuing to, again, you find your small windows, you find your large institutions, and you work with them to help carry it forward. APHA is a massive organization, and so we are not doing this just alone. So.
Fantastic. I see we are almost at the conclusion of the webinar. We are about 2 minutes left, but I did see there were some questions from the audience in the comments. Thank you, Professor Bauer, for going ahead and starting to answer a few of them. There are still two open questions, one of them being from Amanda. This is not a question I'm assuming Amanda meant to write, but I just want to acknowledge how this group of helpers is willing to take on more work on our end and ensure we keep our teens safe and well. So just, I guess, a big shout out to the panelists. Amanda is just saying thank you for taking on this amazing public health work. So thank you for that comment, Amanda. We have another note from Cheryl. Cheryl states, we are a local LGBTQ plus community center covering 2 counties. We prioritize data collection and impact evaluation. How can we make this local info helpful? Local info helpful at a higher level where data is disappearing?
That's a great question. I would say, you know, my first recommendation is if there are researchers in your local, like somewhere in your state at universities that you have identified as sexual gender minority researchers, they might be someone to talk to, because you two could be like a really fabulous collaboration where they can sort of amplify your work at a higher level. But I will just say thank you for doing that work at the local level.
I was going to add to commend you for doing that, because a lot of nonprofits struggle with that because it's burdensome and not always immediately like relevant, but it's critical to, you know, pursue that and maintain those relationships based on the use of those data.
Oh, and Cheryl notes, great, we have a GSR embedded in our team.
Awesome.
We are at 2 p.m., so at the top of the hour. I want to thank all the panelists again for your insightful answers, comments, suggestions, data. This was a really amazing and impactful webinar, and I hope this conversation continues offline. And I will turn it over to Megan if she's available for any last minute comments, questions before we conclude the webinar.
Well, thank you for doing this, and for facilitating so well.
Thank you so
And
much.
I love meeting people from around the country.